approximately 2 minutes. So the first person who indicated earlier was Deputy O'Sullivan.
Thank you very much, and thank you for your presentations. And I do think it's really useful to have the GP's perspective, obviously because of the relationship you have with your patients, and also, as you said, Dr. O'Shea, the fact that in the early months it is the GP who primarily deals with the issue. So I just want to ask a couple of questions. Firstly, just in response to what you said about rogue agencies, Dr. Hanley, if you could give us an indication as to how much information, just as to how, how big an issue this is, and if you're aware of advice being given. And maybe I'll just complete the questions first. And just secondly, just I suppose in the context of that, because there isn't a process of referral, you can give the patient her chart, but you can't actually engage with the provider of health in another jurisdiction. How much difficulty does that cause for the health of the woman? If you can maybe answer that. And my final question just relates to the issue about contraception. I think you said again, Dr. Hanley, that abortion rates are lowest where contraception is most available. Are there still barriers to accessing contraception in Ireland? And how, would you think that reducing the barriers and having more effective access to contraception is actually much more effective in preventing or reducing the number of abortions rather than what we have now, which is the criminal situation and the Eighth Amendment? I know you don't want to make a statement directly on the Eighth Amendment, but I think you certainly implied that the Eighth Amendment makes it very difficult for GPs to deal with their patients adequately.
Thank you very much, Deputy. Dr. Hanley, please.
I'll answer the first question first, which is about rogue agencies, and this actually can vary from which part of the country you live in, but it is actually one of the things that perhaps when the HSE agency come and do give evidence, they can give you some more evidence. If you look at the positiveoptions.ie website, there is a tab which states do not be manipulated, because it has been the experience of women in crisis pregnancy in this country, and it continues to be in a very small number of locations, that agencies that purport to be counsellors in crisis pregnancy are there with a hidden agenda and would wish to heavily influence the decision of the mother, of the woman, and would wish to influence the outcome of the pregnancy.
Specifically, just in relation to that, anecdotally in practice, a concern we would have, sometimes people come to us, it is a crisis pregnancy, the impression is that they're encouraged to take their time to make their mind up and to delay. And delay carries a medical risk in this particular care setting. Moving on to your...
It seems like more widespread than maybe we would have been.
It's difficult to objectively quantify them, but we do understand and we do believe that they are a feature of the care environment, and there is a concern, and I think clearly our concern is shared by our colleagues in the HSE Crisis Pregnancy Agency. I'd like to move on to your excellent question in relation to referral, and I suppose really what we have is the classical Irish solution to the Irish problem. When my parents were in practice, it was all about the oral contraceptive pill, which we provided, and we were allowed to prescribe for cycle regulation. So if you had the slightest smidgen of a regular cycle, you were all right. Later on, we were allowed to, I think, make condoms available providing you were married. Now we're able to talk about termination, but we're not allowed to actually make a referral. And from a medical perspective, on one hand, we do say that abortion is a relatively safe medical procedure, and there's objective evidence that that is the case. On the other hand, the experience that we're subjecting women, particularly who travel for abortion, from a psychological perspective, basically it's traumatic to consider any sister or mother or daughter travelling to a UK abortion clinic under these circumstances, sick with the symptoms of early pregnancy, the uncertainty of what they're embarking on, the cost, etc., and so on. In that context, many of us believe that it makes far more sense that if a referral is to be made, that the referral can be done in the medical fashion, or that other solutions are examined. That is the situation in relation to making a referral.
And then to answer the third question, which is, are there still barriers to accessing contraception? It is true to say that the barriers to accessing contraception have diminished exponentially in the last 20 years, and that should help the situation. That probably is one of the reasons why the numbers who are travelling from this country to other jurisdictions has dropped as well. So that's almost certainly directly a result of that. There are still too many myths out there. Too many young women think that the contraceptive pill puts on weight. Too many women rely on emergency contraception. Now, the failure rate of emergency contraception used to be 1 in 20. That is improving as emergency contraception improves. So there are improvements constantly, and there are some very good initiatives, such as the website called spunout.ie, really good health promotion and information available. So that is, thankfully, an improving picture.
Which we would add, we would concur with the observations of our colleagues from the WHO yesterday, who indicated there is a significant difference in terms of availability of contraception between our health system in Ireland and, for example, the NHS. There are clear steps that can be taken to improve, and they're educational steps as well as resourcing steps. We do regard the service we provide in our practices, but there are not enough general practitioners in this country, and we're particularly short of practice nurses, and that has a ramification in a whole lot of other areas, including the area of reproductive health.